How does Mingle Health go get the data from ACO member practices?
Oh, great question, Bernice. It becomes an interesting exercise in problem solving, and most of us here at Mingle perversely enjoy that challenge. There's always a way. There's always a best way, though the best might not necessarily be an easy way. It generally involves a discussion with each practice of their resources and barriers. Now, it might be self-guided using our self-help tools. Our staff might guide the discussion, or you may have a local technology-oriented infrastructure that can pitch in. Like sometimes the the ACO can have some staff that helps. That often they learn the approaches from us and then take that from practice to practice. Now, it's always useful to look first for technical interoperability tools that come with the EHR. Now, certification regulations are steadily pushing these to broader availability and better operability, but many remain unusable. Barriers include content that is missing, key data that's required for patient identification, eligibility determination, or performance determination. Documentation and workflows that do not populate structured data fields that can be recovered in these, or excessive cost to purchase the module from the vendor. So, and what I'm saying here is that even though these applications, these capabilities need to be certified by your EHR, certification standards are loose enough that doesn't require that they work, or that you're using it in such a way that it works, or that if it works, you can buy it at a reasonable cost. So these are all barriers to those interoperability standards. Now, most EHRs and practice management systems, where we get most of our data, have innate reporting capabilities. Often they're not suitable for similar reasons that interoperability tools don't often work, but they often can and do produce big raw flat files of data that include the data we require to analyze these measures. In one sense, we can get a list of patients and their demographic capabilities out of practice management system to determine who's eligible for each measure, and we can get data from the EHR from these tools that we can match with to determine the performance. For instance, the hemoglobin A1C measure, if you can give us a list of all your hemoglobin A1Cs in the last year or two with a patient identifier to that, that's typically enough to build the hemoglobin A1C measure. Those data sets you provide to us may be more than we need, but that's fine. It's easy to disregard data, but it's possible to infer data that's not there. Now, all EHRs and practice management systems are built on a database, and every database can be technically queried for the data we need. Think again about those big raw data sets we can get, all of the diabetic patients, all of the hemoglobin A1Cs, all of the immunizations, et cetera, et cetera. Now, it requires read access to the database. That is, whoever's going to pull that data has to be able to get in and has to be able to read it. They don't have to be able to change. They don't have to be able to change it or write to it, but they need to be able to read it. And that's how security is generally configured. You may have no access to the database, read access, or read-write access. Now, that access is often legally denied by contract, or it could be physically blocked by whoever's hosting your application if you're not hosting it yourself, or you may not have access to someone with technical expertise to go get it. Now, that technical expertise to go get it might be available from the vendor, the EHR vendor, or the practice management system vendor, might be available from the host who's managing your technical environment. It might be available from your revenue cycle company or billing company that helps you with your billing. It might be available for hire. You can find people with Epic skills or eClinical work skills or next-gen skills, Allscripts, whatever system you're using. There are people who are familiar with the database and know how to write the technical language that pulls those data sets. Now, if all else fails, chart abstraction is available to anyone with adequate knowledge of medical concepts and the willingness to open and read charts and record the data. And that data is typically recorded on a spreadsheet, and and provided to the vendor, and those have adequately populated, we can integrate into any group submission, any APP submission, or even a MIPS submission. It can be used as a sole source of data or as a supplemental data to integrate with everything else. So there's almost always a way to do it, and we, again, with a willing client, we can succeed 100% of the time. Although the cost, effort, skills can be barriers that you choose not to overcome. Great question. Thank you very much.